Welcome to Smart IT Strategies for Imaging Growth and Quality Outcomes, sponsored by Carestream. I'm Mary Tierney, the Chief Content Officer of Clinical Innovation and Technology and Health Imaging, and I'll be moderating our discussion today. We're going to hear from Christina Kermanchachi, who is the Chief Architect for Health for Intel Corporation, Maureen Gaffney, who is the Senior Vice President of Patient Care Services and Chief Medical Information Officer at Winthrop University Hospital in Mineola, New York, and Dr. Elliot Siegel, Professor and Vice Chair of the University of Maryland School of Medicine, Department of Diagnostic Radiology and Nuclear Medicine, and Chief of Imaging at the VA Maryland Healthcare System in Baltimore. We will be talking about how the convergence of healthcare reform and big data and medical imaging is changing the CXO's approach to operational design. CXOs must now collaborate with radiology and IT on intelligent IT strategies that do far more than improve department and hospital productivity and efficiency. These strategies also must facilitate image exchange, mobile access, and patient empowerment while unlocking new financial models for growth and scale, as well as supporting images inclusion within Meaningful Use Stage 2 and position within the broader picture of healthcare IT, as well as business profitability. Christina Kermanchachi will detail the IT implications of big data and medical imaging as well as care coordination, while Dr. Elliot Siegel will talk about the 10 things to look for in your next generation PACS. Maureen Gaffney will share her experience collaborating with the radiology department to build a strategy that offers anywhere, anytime access to images, a reliable vendor-neutral archive, diversified disaster recovery, predictable expenditures based on a pay-per-usage fee for PACS, and flexible growth enabled by cloud-based services. Once we go through the presentations, we'll roll into a live question and answer session, during which time you can submit questions for the presenters. They will answer them live. So, Christina, I hope you can start us out with a look at big data and medical imaging.
Thanks, Mary. I'm here to talk to you today briefly about the IT implications and considerations of big data medical imaging. The rise of healthcare big data is a significant challenge for all of us. The explosion of medical images that need to be reliably archived while providing high-performance image rendering, retrieval, and care coordination across multiple clinicians in a region is no small challenge. Just consider the primary storage requirements of diagnostic imaging today. An average hospital requires about 175 terabytes for images and clinical records. Additionally, they're going to create 15 terabytes annually over time. If you couple that with the data archive requirements, sometimes as long as 20 years, this can represent a significant storage challenge. So in 2006, the primary copy storage for all U.S. imaging was estimated at 24 petabytes. And what we mean by primary copy storage is it assumes no duplication for RAID, archive, and disaster recovery purposes. By 2014, the U.S. primary copy storage is expected to reach 100 petabytes. Now, couple that with the complexity and sophistication of advances in techniques in medical imaging today, such as 3D reconstruction, multiplanar reformats. A typical CT image slice is about half a meg, yet 3D rendering can result in as many as 10,000 image slices at 5 gig for a coordination as a use case. That's ultimately, at the end of the day, what we're all trying to deliver in healthcare today, delivering high-quality images and the latest health information to specialists, clinicians, and patients at the point of care. So if a patient is coming through the emergency room having urgent radiology studies done, consults with neurology, some surgical procedure, and then proceeds into intensive care, that's a lot of different types of information, whether it's in a single hospital or you're consulting with specialists, perhaps using teleradiology across the region. This is critical that we're able to deliver this in a secure and high-performant manner. So one of the most cost-effective ways of deploying capabilities in this case is really deploying cloud-based imaging archives designed for high availability across the region, including local cache and tiered storage mechanisms. And the picture at the bottom depicts, establishing a cloud vendor-neutral archive, utilizing, different trust broker mechanisms, and taking into account, the security capabilities and graphics capabilities and perhaps network bandwidth availability of the different devices shown. So when you're deploying, whether you're deploying teleradiology in a particular institution across a region, it's very important that you take into account, an end-to-end usage model like this, and really take into account, like I said, what is the user authentication level at each of the different endpoints, what are the capabilities of that device, and have you suitably rendered the information accordingly. What are some of the general deployment considerations when you're doing cloud-based imaging? Well, really, whether you host it internally yourselves or you're looking to work with an outsourced hosting provider, there's a number of different key details that you really need to pay attention to. I'll just touch upon a couple of these. So, for example, recovery time objectives and recovery point objectives. Those are fairly, complex terms, but in essence, what they really mean is how long can you afford to be down and how much data can you afford to lose, right? In a hospital situation, that's very critical, and you need to design systems and importantly, review contracts and service level agreements accordingly. Are you working with a hosting provider and a service provider who's got a proven track record of full disaster recovery plans, business continuity? Do they fully understand the data protection regulations in your region? Have they delivered a defense in depth, secure perimeter requirements? So all of these things are important considerations to keep in mind as you're designing an imaging solution. So let's take a look at some of the technology implications of satisfying cloud-based medical imaging. Well, usually the first indicator is that you're out of storage or perhaps you're out of data center capacity and you're going through some difficult decisions of do we rebuild the data center, do we even have the IT expertise to perform the ongoing management, do we look at potential outsource options, and this is true of whether you're a single institution or you're trying to establish medical imaging across multiple institutions, perhaps across a region. What's frequently overlooked is the importance of upgrading the network and the compute infrastructure at the same time. Because if you only focus on one aspect of these three, you're going to be pushing the bottleneck around, and you may find that you'd come up with a plan that would satisfy you for the next 3 years, but in reality, you've caused problems elsewhere in the system. So again, it's very important to take advantage of expertise of different solution providers and really take a look at what's the best solution here. The other thing is that there's been significant improvements in security technologies and hardware-assisted security and processor advantages over the last few years, so that really you should be able to deploy encryption everywhere without the performance penalty. So it's something important to keep in mind. Innovative cloud services offered by Carestream, they've really designed their solution offering around the care coordination model that we were describing before. Whether you're trying to do teleradiology across a region, maybe make maximal use of your scarce radiology expertise. Maybe you want to set up a cloud portal so that physicians and patients alike can get the latest healthcare and diagnostic imaging information. They can address your long-term archive as a service, PACS, and collaboration. So all of those are different capabilities that are supported by ViewCloud. Now, ViewCloud has been designed very carefully with an active archive and disaster recovery and security perspective in mind. They always place on-site at a service access point, whether you're choosing to adopt on-premise or off-premise hosting. So the Carestream solution provides for a local cache in the event of network outage. Anywhere from about 18 months to 2 years of information is always locally stored for immediate retrieval. And yet it delivers a cost-effective yet high-performance tiered storage mechanisms, maintaining control of master images, performing data integrity checks, and assuring compliance with data protection and medical image archive regulations around the world. So when you're working with a medical image hosting provider, it's critical to ensure that an end-to-end defense in-depth approach to security and data protection, including physical, administrative, and technical controls, are in place. And Intel works closely with industry partners like Carestream to optimize their use of the latest hardware-assisted security features from client to cloud. So as you're thinking about adopting cloud-based imaging, you're really talking about shifting to a pay-as-you-go model, really shifting CapEx to OpEx while taking advantage of the latest technology innovations. Healthcare institutions can afford the steep investments required to upgrade their infrastructure to cope with big data, and the shift to operational expense frees up scarce capital and, more importantly, critical expertise and resources to focus on patient care and advanced healthcare service delivery.
Well, thanks, Christina. So now we're going to move from big data and care coordination and the cloud solutions that Christina talked about and a little bit more into the radiology department, specifically to look at next-generation PACS. So, Elliot Siegel, this is your domain.
So this is the 19th anniversary. It was 19 years ago that the Baltimore VA Medical Center made the transition to a completely filmless radiology department, which was really a very interesting and kind of scary time for us, and it turned out to be incredibly successful, and we've been able to document in many different types of studies looking at productivity and cost savings and improved safety and patient care over the years, all the advantages of making that transition. But now it's 19 years later in the year 2012, and it's time for us to pick the successor to our original PACS system. Having the world's first PACS system also carries with it potentially the disadvantage of having the world's most antiquated system. And what we really want to do is to create a visionary system based on all the research we've done and based on everything that we've learned in the last 18, 19 years or so. So if we're going to buy a new system that we may have until the year 2030, what are the things that we're looking for? Well, the first thing we want in our next generation smart PACS system is the equivalent of what's been referred to as a vendor-neutral archive. And the term's been used many different ways, but when I say that we're looking for a vendor-neutral archive, I want to have an archive that is non-proprietary and supports multiple different PACS vendors, multiple different image visualization systems, and can take the many different components that we have currently that produce images and display images and be able to provide storage for those. I also want it to be neutral in its ability to be able to utilize many brands and many different types of storage systems. I want much more than just a DICOM archive. I want it to be able to support many different types of images. And as far as migration, we've really had some major challenges over the last 18 or 19 years where we've had to migrate from our original optical codec jukebox up to plasmon storage and then to EMC storage. And as we've had difficulty with our vendor in doing that migration, it has significantly slowed down our ability to be able to keep up with the latest version of the vendor software. And so we're really still on an early version of that software because of challenges that we had with migration. So I want this new vendor-neutral archive to make it as easy as possible for us to not have to worry about the upgrades and the storage of data. I want it to support radiology, nuclear medicine, cardiology, and many specialties outside of just diagnostic radiology. I want it to be able to store all the thin section data that we create from our CT scans, which might be as many as 1,000, 2,000 images per study, or in some cases even more. And I also want it to store forms of what I'd refer to as raw data, including nuclear medicine raw data, MRI, tomosynthesis, and maybe even the raw CT data, because we're finding more and more uses where we have the capability of being able to call up the raw data and be able to create advanced visualization displays. And so I want to be able to keep those data for comparing an old with a new study. I want to have the data archive shared with not only our radiology PACS, but also advanced visualization and cardiology systems and subspecialty systems. I don't want to lose the annotations that we make that are frequently vendor-specific, but I want to be able to keep those. And so I want the vendor-neutral archive to be able to sort out and in some way be able to help me standardize those annotations. I want my storage to scale upward indefinitely, and I really want to just overall get out of the business of worrying about storage and just think of archive as a commodity. The number two thing I want from my smart system is a much better way to be able to do communication. What we found is that the communication loop and closing that loop may be the biggest challenge in radiology today. And so what I want for my next generation system is not only for it to notify referring clinicians of unexpected or important findings, but also to record acknowledgement that information has been received, and then to do automatic follow-up of recommendations. If I recommend that a patient with a unsuspected lung nodule on a chest X-ray get a CT scan, I want to have a mechanism to follow up and make sure that that's actually done. I also want my smart PACS system to be able to have a much better mechanism for reporting and personalized medicine. And so I want it to be able to do lesion tracking, for example, so that I have the capability of being able to identify a lesion from a previous study and be able to track that lesion and show how that lesion changes with time. I've done work with the National Cancer Institute in imaging informatics, and I'm absolutely convinced that the future is going to be supporting personalized medicine. And so the work that we have done at NCI has looked at the creation of specific reporting templates, for example, for reporting out brain tumors, where we can record information on a workstation that we use to visualize images and have that data stored in a standardized format and then allow us to be able to take those data and correlate it with genomic data and lab and other clinical data. And so ultimately, I should be able to use the radiology report that was generated in a structured manner to be able to generate something like a patient survival Kaplan-Meier plot, or to be able to make specific recommendations for treatment. Workstations and visualization, I think what's going to become routine is the use of advanced imaging such as sagittal reformatting, coronal reformatting, what's referred to as maximum intensity projection for pulmonary nodules, the ability to take thin section slices and combine them into thick slices. And those things which used to be relatively exotic advanced visualization features in our future smart PACS are going to be completely routine. And so here you can see a CT image using maximum intensity projection, and according to the radiology literature, it significantly improves our ability to find subtle lung nodules. And so rather than using these in special advanced workstations, these will be included routinely as part of the review protocol in every single PACS. As far as innovation in delivery of images, I'm absolutely convinced that the trend will continue with server-side rendering, similar to Google Earth, where the image processing is actually done at the server side. And so one can immediately start looking at different 3D or multiplanar images rather than waiting for an entire data set to download to a particular client workstation. And we're also going to be seeing a lot of the processing that was originally done by our technologists or a special 3D lab done automatically on the computer. So here you can see an automated center line that's being drawn through the aorta, and here's another image where you can see a cardiac template where the processing of a cardiac study is completely automated, and then on this image you can see that the coronary arteries are actually labeled by the computer, and the computer is able to provide preliminary quantitative data as far as degree of coronary artery disease. As far as the future, I think future visualization systems may support direct visualization of raw data sets from the CT data, and that's going to require incredibly fast processing that we might get with server-side rendering, and actually had the capability of adding to a journal content the ability to sign on and interact with the data set using advanced visualization tools. As far as next generation of PACS software, I want it to be really smart, and I'd like to see different vendors' applications running on a single host. And so there's a standard in radiology, DICOM Working Group 23, that allows one to be able to run a workstation as a host and to be able to run different applications. And so what this means will be in the next generation, we might have the equivalent of iTunes for imaging. And so I may like one vendor's cardiac CT package, another's virtual colonoscopy package, another's ultrasound or nuclear medicine viewer. And so having one host that I can run my very favorite best-of-breed applications, even if they're from different vendors, is where I want smart PACS to go in the future. I also need to have a zero-footprint application so that I have the capability of being able to run browser-based display systems for clinicians and ideally for our radiologists, so that we don't have to worry about administrative privileges and installing specific software. And I think we're seeing more and more of the PACS really smart vendors going towards this zero-footprint application that can run entirely from the browser without installing additional software. I also want better support for including AIM, the annotation and image markup specification and model that came from the National Cancer Institute that would allow me to make measurements on the screen in a standardized way and have those measurements directly sent over to a reporting system. I'd also like better support for the new DICOM, CT, and MR objects, which could increase performance and increase my functionality for reviewing those images also. And I'd also like to see support in the next generation PACS system for being able to store and track radiation dose information and also information related to a contrast injection that I've done. So monitoring contrast and dose would be really helpful in my next generation smart PACS. And just a final couple of things. I'd like to be able to output images directly to a patient personal health record, or potentially even electronically transfer images on demand. And so I think we're going to be replacing CDs in the future that we're using now, which are really very problematic in lots of ways, with direct digital transfer of images to different outpatient clinics or another hospital or directly to physicians' offices. And I think we could even see adoption of Facebook. I know people might be hesitant to have their medical images, but people seem to share every other part of their anatomy on Facebook, and I wouldn't be surprised if in 5 to 10 years people start figuring out, clever ways to utilize social media as well. And so in the next generation PACS, I think this electronic transfer of images is going to be commonplace. And just a final point, I think the next generation of really smart PACS systems are going to take into account artificial intelligence types of technologies, such as the IBM Watson technology that was used for Jeopardy. And, some of the work that I'm doing is looking at researching and helping to create what I would refer to as the automated radiology resident or fellow, where the PACS system could, the same way that my resident or fellow does, pull information from the electronic medical record, from previous progress notes or operative notes or other radiology reports, and provide for me a really good, pithy summary and synthesis so that I could be a better, safer, and more productive and more effective radiologist.
Well, thanks, Elliot. So now we're going to move from radiology to the healthcare enterprise with Maureen Gaffney.
I'm here to talk to you today about how we can leverage imaging technology for organizational success. We're a 590-bed academic medical center located on Long Island in New York State. We serve a very large population, a very diverse population across all of Long Island, as well as into Queens and New York City. We have a very large acquired practice strategy as well, so we did have to be cognizant when we were selecting a risk PACS to make sure that it had the capabilities of imaging exchange across not only the inpatient population but also the outpatient population and the ambulatory setting. We are actually in the middle of our risk PACS implementation right now with a new product. We had two disparate systems that created our risk PACS solution. They were legacy systems. The decision to go with those two different systems was based on financial decision-making because there was a understanding or a belief that having the risks similar to our physician billing system in the outpatient setting was going to be a benefit. We soon found out after implementation that just created more challenges for us. We lived with this system for over 10 years, and it was quite challenging for the organization. It was non-DICOM. It had proprietary software as well as other applications. And to just add insult to injury, our risk solution was starting to sunset. So we were really had our backs up against the wall in regard to having to make a decision and what was the right direction we wanted to go in as an organization for getting a radiology information system as well as a PACS solution that was going to position us well for our growing organization as well as being progressive with the technology. We decided to go with an integrated risk pack solution. This provided us with a unified platform. It provided us enterprise access, so all of our providers would have access to the images as well as the results, whether you were an inpatient practitioner or outpatient practitioner or in your private practice. It also, very importantly, provided us with a vendor-neutral archive. That enabled us to really bring all of the images across all of the disparate PAC systems that were throughout our organization, because we did have PAC solutions in private practices as well as in ambulatory settings, that we wanted to make sure that we had one single imaging repository for not only our radiology images, but also for our other disciplines such as cardiology and vascular. On top of that, we realized that we were very, very limited in regard to our ability to archive our images over time, of course, in the more traditional model, such as the archiving, mass archiving solutions of the previous generation of radiology information systems and PACS. So we explored our options, and we could have stuck with that same type of technology and that type of architecture, but we felt in order for us to be well positioned for the future, we wanted to utilize cloud technology for our archive solution. We also felt that the clustered environment that our RISC-PAC solution offered us was very beneficial, so we could load balance. We wanted to make sure that our network was not going to be overwhelmed with the images and the image exchanges that were going to be happening across the network. Also, having a RISC-PAC solution that was integrated provided us an opportunity to have our services streamlined. In the prior world that we were living in with the disparate systems, very often we had finger pointing across the RISC and the PACS because not one vendor wanted to take responsibility for whatever the issue was that was being presented. The decision to go with cloud actually was a very easy one. We thought that we were going to get a lot of pushback from our IT department as well as from the providers because of the newness of that technology. Winthrop is fortunate that we are considered progressive in the way we use health information technology, so I believe that we had already done a lot of that groundwork with converting some of our naysayers of the past to be more open-minded in regard to the newer technologies. And once they understood the benefits of cloud services as opposed to the more traditional archive solutions, it was actually a very easy sell. The concept of having a archive solution that could grow with the organization and not be limited to the hardware purchases and the capital costs that are associated with that moving forward provided the organization with more flexibility and eliminating that obstacle that was very often a challenge for us in the past, well, as we grow. As you know, more and more hospitals, more and more hospital systems are reaching out and partnering and acquiring not only physician practices, but also other types of healthcare delivery organizations such as nursing homes, etc., that we have to remain nimble in that environment. Otherwise, you do get held up with those challenges of that hardware, those hardware needs. It also improves the reliability and the availability of the images. I'm going to show you in the next few slides some of our configuration here at Winthrop utilizing the vendor-neutral archive as well as the cloud technology that provides you that backup system and redundancy that is so important in taking care of patients, making sure that those images are available at the right time in the right place and not having to worry about the network piece or even the disaster recovery piece. It also avoids technology obsolescence. The ability to grow not only your organization but your system and keep the latest functionality available and the upgrades much more simplified in their implementations, really does offer a great advantage to an organization that wants to remain nimble and expandable without it being a major project every time you take on more customers as well as more access points for images. This way you just continue to have that flexibility moving forward. In the next two slides, you're going to see that the actual architecture and the schema of how we are configured here at Winthrop University Hospital. You'll see that there's many, I'm not going to get into this in detail, but just for your own references, you can see all the different connectivity points that offer that redundancy and that opportunity for reliability just in case any part of that system breaks or is slowed down. We make sure that there is a continuous feed of information that is available for our providers. So in the event, if you go to the next slide, in the event that there is a primary data center dysfunction, you can see that there is still that backbone and those links available to us. So this way the downtime process is extremely transparent to the end user. Those images continue to be available to us no matter where that data center might very well be having issues. So in addition to the archive solution and the availability and reliability of a RIS-PACS integrated system, there's also great benefits to the ability of having a RIS that has clinical decision support built in. We were very excited about this because being progressive within our organization and having a full EMR in our clinical areas, the expectation is that all of our systems would have some type of CDS ability. The clinical decision support that the RIS offers really guides the providers and the ordering providers to make sure that the indications for the tests are appropriate, as well as other clinical decision support rules that could be customized to your organization's goals. Benefits to having integrated clinical information that's bidirectional, because the radiologist often has to work in a separate system in the more traditional models and not have easy access to certain clinical information that could be pertinent when they're reading that image. So now, with the ability to send that clinical information to the radiologist from the EMR, offers great benefits for our patients. It also, the RIS-PACS solution increases accessibility to the images, so even in the outpatient setting or in the remote settings, when there's a question regarding the patient's condition, these images are available to the providers that are involved in the care of that patient, not just the radiologist. There's also an enhanced viewer capability for our specialists. So that is not workstation dependent. This is extremely beneficial to us because of our patients and the wide scope of where our patients are being cared for across the island, that our physicians and the other providers caring for those patients could have access to not only just the images but also the enhanced viewer capability. Image exchange capability also is extremely beneficial. We found that there's more and more demand for the ability to share that information across the different sites, and they don't necessarily have to be connected to our RIS-PACS. They could be even a separate system, and our system does have the ability to exchange images, which really expedites care and also reduces the chances of redundant testing. We also benefited from having an integrated peer review capability within the system as well, and that has really helped us out a lot in regard to our quality processes and making sure that we have the ability to sort out different types of images and different types of results so there can be a comprehensive peer review process. Obviously, having a system that is more efficient, easier to access, has more information in it than your more traditional risk packs, has provided an opportunity for greater satisfaction among not only our radiologists but also our technicians. The radiology technologists have better work list integration with the modalities, which helps their satisfaction through efficiencies as well as more streamlined workflows. And our radiologists really appreciate the faster image viewing and the ability for those images to be transmitted. Information sharing, of course, between the technologists as well as the radiologists has improved, as well as the academic teaching files. This was a big challenge for us because we have our radiology residency program here at Winthrop, and it was quite onerous to have the residents be able to import or export images into their presentations. The ability to have a JPEG image available to them provides easier import and export capability. And of course, the web-based solution providing the image access remotely has just, the physicians are coming to me on a regular basis, the non-radiology physicians, and just saying how wonderful it is and how easy it is for them to access the images from home as well as from their offices. This is also something that I feel is going to lead to more patient satisfaction as well. The frustrations that patients feel with waiting for results, waiting for images, waiting for CDs, whatever the mode of information exchange might be, will be eliminated because now there'll be direct access to those images. In addition, we have gained tremendous efficiencies. We've lowered our labor and IT costs because of the efficiencies within the actual system itself. With cloud computing, the IT staff support has been minimized. We're really dealing with more network support, but the actual archiving and other types of support that was IT dependent has now been moved to the cloud vendor. In addition, the other business and financial benefits was that we have a more predictable operating cost. We don't have to keep going back to the well, so to speak, for capital funding each time we want to expand our solution. And of course, most organizations now are being very cognizant in regard to their readiness for the meaningful use criteria, and Stage 2 has, in the proposed rule, it's evident that they have started to, CMS has started to understand the value of image exchange. In conclusion, the bottom line for most organizations now is being prepared for what's coming down the pike in regard to healthcare reform. We believe here at Winthrop that having an integrated risk pack solution is one part of our strategy to be best prepared for what's ahead. Health information exchange is definitely going to be a major part of the solution for many organizations to be ready for the bundled payments, ACOs, as well as more and more of the measures that are coming out of CMS. We know already that we're being measured for how often we're doing tests in certain scenarios. There's new core measures that are outpatient core measures as well as inpatient core measures that have efficiency as the base of that measure in regard to radiology and other imaging measures. So we know that having this integrated risk pack solution, using the cloud technology to offer us more and more storage so there's more information available for exchange is only going to improve image and result access, which will in fact reduce test redundancy because we will have the ability to share that information and therefore not put patients through unnecessary testing. But yet, being cognizant that we want our physicians to have easy access to that information. We cannot make it onerous for them to get that information. So having the ability for that health information exchange interface with the risk packs, so therefore the risk packs as well as the RIOs will have the ability to exchange that information, which is going to be one of the proposed rules for meaningful use stage 2. So we feel that we've made the right decision here going with an integrated risk pack solution with cloud computing as an archive solution because it will definitely prepare us for what's coming very soon and position us well for that. So at this point, I've concluded my part of the presentation and would be happy to now turn it over for the question and answer period of this webinar.
You may now begin the question and answer portion of this webcast.
Well, thanks for joining us for the live question and answer session for Smart IT Strategies for Imaging Growth and Quality Outcomes, which is sponsored by Carestream. I'm Mary Tierney, the Chief Content Officer of Health Imaging and Clinical Innovation and Technology, and I really thank you for joining us for the Q&A. Some of you have done so already, but if you would like to ask a question that could be answered live, please just type it into the dashboard where it says Ask a Question at the bottom of the console and hit Send, and we'll answer as many questions as we can in about 15 to 20 minutes or so. So joining us today live on the line, we have Christina Permanchachi, who is the Chief Architect for Health for Intel Corporation, Maureen Gaffney, who is the Senior Vice President of Patient Care Services and Chief Medical Information Officer at Winthrop University Hospital in Mineola, New York, and Dr. Elliot Siegel, who's Professor and Vice Chair of the University of Maryland School of Medicine, Department of Diagnostic Radiology and Nuclear Medicine, as well as Chief of Imaging at the VA Maryland Healthcare Center in Baltimore. So let's get started with some questions. Maureen, I'm wondering if you actually can take the first one, which talks about Stage 2 meaningful use. The Stage 2 meaningful use final rules are out. How do you think that your decision to move to the cloud can help you to achieve these new measures?
Thanks, Mary. Yes, well, Stage 2 meaningful use, the final rule obviously has included the capability for organizations to have the functionality of being able to exchange images. So having the cloud facilitates the being able to receive the images, but I think there's still a lot of details that need to get worked out with this particular functionality. Many of the exchanges are going to be at the health information exchange level, not necessarily hospital to hospital. So I think the cloud just offers you more flexibility with how you'll be able to store the images and be able to retrieve them easily. I'm not really too sure if, I don't think that's going to be our only problem with that particular part of meaningful use stage 2.
Okay. And what, as a follow-up kind of, what about patient engagement? How are you planning to address that?
Well, patient engagement at our organization, we're planning on addressing that through a patient portal at our hospital local level. We also have the option of moving them from our patient portal to the RIO's portal as well. I know there's some organizations within our RIO and within our region that are going to be relying on our RIO's patient portal for that measure, but that will be particularly challenging because, as many of us know, this measure is measuring a certain percentage of our patient population that must be accessing their information, and that's something that organizations don't have full control of. So that is going to be a challenge.
Okay. And you did mention health information exchange. There's a question about, how is that set up? Is it public or private?
The health information exchanges in New York State, we have a mixture of, most of them are independent nonprofits that we are participating in. There are also some RIOs that use health information exchange engines that are part of the HEAL grants within New York State. But New York State is also working on a state health information exchange called the SHINY, the State Health Information Network of New York, which is going to build a common platform for all of the RIOs to connect to, which will be more of a public type of entity.
Okay. Christina, there's a question perhaps more specific, I guess, to kind of a big data type of thing. Now, how did you come up with the data requirements within your presentation? Are those specific for specific size hospitals?
Those are actually just examples. So I don't know if you plan to distribute the slides or not, but I can provide links to the background research. We've done a fair amount of research in this area, so I think those are fairly good, representative examples. And certainly, I think Elliot mentioned a number of comparable sets of data sizes as we move from traditional imaging to 3D reconstruction and things.
Okay, and while we're having you speak, perhaps we can move on in just a couple of questions more specific to cloud. What makes cloud a less expensive option, more operationally, and does this apply to all facilities of all sizes?
Absolutely. So, one of the considerations you have when you're thinking about approaching cloud is certainly what level of IT maturity and IT expertise do you already have. So a lot of times people, if you don't have a lot of the expertise in-house, you're certainly looking already to fulfill that in different ways. And a lot of people are perhaps intimidated by cloud, but we look at it as a natural evolution from managed hosting from the .com era. So a lot of it is just making sure you're working with a good partner and applying industry best practices. So a lot of the cost savings actually come from the potential to share some of the core infrastructure across the region. So Maureen just mentioned a number of great examples from New York. Sometimes you'll have institutions that have a great deal of expertise and some of that infrastructure already in place, and they'll be looking to perhaps to share those capabilities, recoup some of their investment with other institutions in the region. It's a great example. And in some cases, you're seeing a lot of development of HIEs that, as she mentioned, a combination of public and private investments for the same reason. Really, if you think about what it takes to set up an HIE, or even if you're just focusing on the diagnostic imaging portion, there's a lot of core capabilities that have to be set up, and so we think about it both in terms of infrastructure costs as well as IT and clinical expertise. So I'm sure you're all familiar with the need to share scarce radiology expertise across the region. So it's very much the same idea. And if you think of then like the capital expenditure costs, one of the things that we hear routinely in working with customers around the world is it's very hard for hospitals. Their focus is on delivering the best possible care to patients, not necessarily in focusing what should I what are the latest storage subsystems that I should upgrade to, right? So there's a lot of technology changes that are continually happening. A lot of it's great because we're actually seeing higher server density, much lower power requirements, and the like. So there's definitely an incentive to reinvest in equipment quickly on a regular basis. But if you if you're looking at outsourcing, some form of cloud computing, I think the goal here is a lot of times your outsource partner can leverage significant economies of scale in doing that, equipment refresh on your behalf, rather than you having to take out of your budget. So we talk about that as, shifting capital expenditure out and recouping much of your operational expense as a result. Okay.
What are the benefits of cloud with regard to mobile deployment?
As in access across mobile devices?
Correct.
Probably. Again, I think it gives you a lot of flexibility. You want to be very, I touched upon this briefly about the security considerations and understanding, how can you best deploy secure installation using effective policy management, for example, understanding the different security profiles of the devices that are out there. Many institutions are grappling with what we call bring your own device, for example, so people want to bring in their own smartphones or their own tablets and whatnot. So it's important to combine that with an effective mobile device management, both system and policies around that. That's something that we talk about pretty routinely. And cloud computing, again, I think, I'm simplifying grossly here, but if you've got the expertise in-house, your teams are probably already looking at, how do we effectively support these different mobile devices. And if you don't, then, it's yet another thing where you can really take advantage of the capabilities of a hosting provider to kind of sort through all of that.
Maureen, do you want to add to that?
I agree with you, Christina. we are grappling with that in our organization with the request to use own devices, and we are trying to develop some type of mobile device management policy. But I think I'm not so sure the cloud offers us any more any real options other than just that it's going to just be easier to just access the images. The mobile device policy management is really where we're getting stuck here because we still have such a hybrid in our organization of different types of servers, different types of systems that we're going to have to give them access to, and it's a huge challenge for us. I know we also have two different schools of thought here. We have some of our more rigid, more traditional IT people that are like, no, we don't want that. We don't want that responsibility. Right. We have to control this and police this very, very closely. We can't give them permission. Where we have more of the forward thinkers that understand that this is a social norm. That's we can't keep denying it. So we're going to have to try to make it work. I don't think there's an easy answer. I think cloud, I think it will help in the sense that it's there, and we'll just have to give them that. It's easier to access the information, but it's not. That wasn't the challenge. Getting the information to the mobile device isn't the challenge. It's how you trust the people that are going to have those mobile devices and have access to that information, how they're going to use it, and make sure it stays secure.
I guess I could add to that. I mean, I don't know if we're able to send follow-up information afterwards, but we've got a number of industry proof points around this. And certainly on the business side, there's ample evidence about how incorporating mobility into healthcare delivery significantly improves both the quality of care and reduces costs. But certainly one of the things we do frequently is work with both the business and the clinical and the IT teams in order to deliver effective solutions around that. And certainly, we see both sides. We see both, tremendous concern and need to be cognizant of the data protection regulations. And how do you do that both within an institution, and then most people are then traveling across the region. For example, maybe you're crossing institutional boundaries. Maybe you're interfacing with an HIE. Any of those possibilities exist. How do you, for example, manage federated identity in that process? How do you make sure that the users have employed secure authentication mechanisms? Mm-hmm. So that's certainly something that we work with routinely. That's really, I think, again, going back to the, folks that are working in healthcare really, want to spend their time and energy on improving care, not getting tangled up with, the policies and the technology. And that's one of the reasons why we work with people, to help get over those hurdles. Mm-hmm.
And this is Elliot. In my experience, we're seeing an increasing number of clinicians and radiologists who want to access images, and as you pointed out, fairly large data sets remotely. And so one potential that the cloud offers is easier access outside the enterprise, and the potential to be able to get access that's secure, but not necessarily through the enterprise's VPN, but in another safe and secure mechanism, and also not necessarily taxing the enterprise's VPN, which typically is limited as far as bandwidth goes. Right. So there's the potential for the cloud to significantly improve performance and access outside the enterprise, which is frequently where an increasing number of decisions are being made.
Right. So Elliot, maybe if we stay in the radiology realm for just a little bit, there's a couple of questions perhaps that you could address. How many types of images does your facility manage, such as radiology, cardiology, pathology, and others? And how often do you utilize the raw data that you discussed, and for what purposes?
Right. So speaking to the VA for the moment, we actually have many different ologies that are all storing images in a central repository that would be the equivalent of a DNA, and that includes ophthalmology, pathology, cardiac ECG images, endoscopy, dermatology, pathology, and many other types of of medical images, and we need access to all of those. And then, I'm sorry, Mary, what was your second part of the question?
And then how often do you utilize the raw data that you discussed, and for what purposes?
So that's a great question. So we utilize the raw data all the time. When I'm reading a PET CT scan, for example, I want to compare the current study with the previous study, and just the DICOM data that gets sent to the PACS system is not enough for me to be able to do the sophisticated comparison that I want. The same is true in the case of MR and some of the advanced CT studies. For example, if I want to compare a current thin section CT where I'm doing an advanced visualization with a previous one, I need to have the previous examination available so that I can do that advanced visualization, whether it's something simple like sagittal images or volumetric reconstruction. So for me, being able to store the quote-unquote raw data is important. Some people refer to the raw data as just the thin section CT or MR data, which I think is important to store. But even storing data such as the original data that nuclear medicine acquisition or PET CT acquisition requires is important. And the way we're doing that nowadays is by storing it locally at the modalities. And then we'll go ahead and call up the current and previous study. But each modality then has the requirement to store its own images, to do backup, to do disaster recovery, and it really doesn't make sense to manage multiple disparate archives, even in the radiology department, much less throughout the enterprise, and to have each modality essentially be its own archive. So for me, the potential to be able to store not only thin section, CT and MR and other data, but other forms of preliminary data, rather than just being limited by DICOM, is a really important thing that I'd like to see in a next generation PACS. For right now, I'd be happy to store thin section, CT and MR data, but as time moves forward, I'd really like to be able to eliminate the need to be able to store raw or proprietary data at the different modalities and be able to centralize that with a VNA.
Great. Now, just kind of an overarching, question as far as radiologist workflow. How do you see it changing as reform pushes healthcare to be more patient-centric?
Right. So one of the things that we're seeing as far as patient centricity is the increasing potential to be able to send images directly to patients and to have patients manage them. For example, the University of Maryland is part of the RSNA image sharing pilot project, which was funded by NIH, where we are giving patients the option not only to have a CD, but to also push images to a patient's own directed electronic medical record that includes images. The patients are being signed up. One of the advantages of that is that we don't have to worry about an infinite number of business associate agreements with other systems. We don't have to worry about the fact that a health information exchange might only have a limited number of providers, but not everybody within our area. And so when there's the potential for patients to manage their own images in a manner similar to what they do now with their email and calendars and other documents, then I think there's a lot of flexibility for patients to be able to serve themselves as aggregators of the images. And so one possible modification for workflow would be that when we have previous studies on a patient or an electronic medical record, I would see in the future being able to get information from a patient's electronic medical record rather than being limited to just the record from the clinic that the patient's visiting or the hospital that the patient's visiting. And so, we may end up seeing greater health information exchanges and easier mechanisms to be able to do that, or we might see patient information stored in their own record, or a hybrid of the two, where possibly a patient's own electronic record might just have index pointers to information that may be stored in multiple different places. But I think in either case, it offers the potential from a workflow perspective for me to get more comprehensive information on patients, to have better access to prior studies, and to be able to make sure that the interpretation that I have is available to all the patients' care providers rather than just within the enterprise where I'm storing the report and the images.
Okay. So I guess this is kind of really a question for everybody, but is anyone using cloud solutions for study sharing between institutions? Anyone want to take that one?
So this is Elliot. I can start and say
Sure.
The answer is yes. One of the challenges that we have in what may be the largest shock trauma center in the country at University of Maryland is being able to have ready access to images that come in from many different sites of different sizes. And we have set up a cloud mechanism for those sites to be able to send and upload their images to the cloud, and then we have the ability to access those images. And so it makes it much faster, secure, and easier rather than what we had done previously, what most people do, which is just essentially scotch taping a CD or even a film to a patient as they end up being transported from one place to the other. And so I think that's a really great use case, but there are so many other use cases for being able to use the cloud to interchange images and reports and related data from one facility to the other.
Maureen, how about you? Oh, Christina, go ahead.
I was just going to say that's an excellent example, and certainly we work with healthcare institutions worldwide, and I could list any number of examples, Western Europe, China, and Australia as an example, who are all doing exactly that.
Right. One of the challenges is in a trauma situation in particular, you don't really have the ability to set up a business associate agreement, and it may be that patients being referred from one of the institutions that is not part of a health information exchange. And so having a ready, easy ability on the fly that could be supplemented by other business associate agreements to be able to transfer images digitally and securely and safely electronically, I think can be a major advantage for that trauma use case and many others.
Yeah, exactly, and it's really a great example of what we talk about shared services across a region. So hopefully over time in the U.S., the HIEs will mature to the point where, for example, they could offer that as a service. They could also be hosting the patient, based medical record as well as another opportunity. So I think all of those things kind of really further enhance the ability to share this critical information across institutions in a reliable and secure fashion.
Mm-hmm. And Mary, just would like to add, Elliot and Christina, you both alluded to it a bit. In the health information exchange models that we have right now, we're still dependent on patient consent as well to participate in that RIO or health information exchange organization. And what the cloud offers is an ability for patients that are participating within your system or even outside of your system to still have that the providers can still access information, particular health information specific to the care of that patient. For instance, in our organization, we're utilizing the cloud storage as a solution between our outpatient practices. For instance, in our orthopedic practices, they were on a separate risk pack solution until we put everybody on the same one. So that automatically all of the images go into one PACS and RIS, and therefore when a patient is coming for surgery, those images are accessible within the organization. That's, of course, because they're on the same platform. But we do have the ability to accept images from other PACS solutions, which enables then that patient's information to be available for the provider at the point of care when they're either in the OR or in another office. But I think we still run into the challenges if we were going to rely on HIEs alone, that we still have the consent issues for the patients. So until we have the critical mass of the population participating in those exchanges, we're still going to rely on these other types of exchange models to get the information to where it should be.
Right. And I think we'll just take a couple more questions, just because I want to be mindful of everyone's time. But there is a lot of question as far as the communication among clinicians and things like that. Maybe Elliot or Maureen, I guess this is more of a patient care provider question. But what vision do you have for communication among clinicians, and for example, with lesion tracking over time?
So, Maureen, you want to take that, and then I'll take it?
You go ahead, Elliot. I have to think about that one.
Okay, sure. So when you said communication, you mean between radiologists and clinicians or among clinicians?
Both. both.
So,
in other words, we need to, you mentioned it too. I mean, we need to improve the communication that goes around and close loop the communication and things like that. But what is your vision there?
Right. So as far as closed loop, different people have different definitions of closed loop, and mine's probably a little bit more detailed. In a lot of cases, what ends up happening is a radiology finding is made, whether it's a suspected abdominal aortic aneurysm or a noticed change over time, and that might be associated with tracking lesions. It's really important to have a mechanism to communicate that to referring physicians, and we see unexpected findings come up all the time. And so when that happens, we not only issue it in a report, but we also contact the referring physician and document that we've had that communication, and then documented their acknowledgement. And so I think for most people that is closing the communication loop, which is really important. But what we do also, in addition to that, which I think is important and something that there's an opportunity to add to an advanced PAC system or advanced risk system, is we then track to see whether they've actually followed our recommendations. So what we found was that even when we make a recommendation for follow-up for a suspected aneurysm, unexpected lung nodule, for example, we would document that there was the communication, get acknowledgement back, and then in a month's time, we would find that in only about 80% of the cases had they actually done the follow-up CT or the follow-up ultrasound or MR study. And so we began tracking that and then closing that second loop that had us communicate in another month to say, hey, we noticed that you hadn't gotten a CT scan. We were just wondering whether you ordered it elsewhere or whether you decided that it probably wasn't indicated. And then what we found is that in that second case, we were able to further close that loop by about another 80 or 90%. And so one of the things that I think is really important is as we track lesions over time and find significant changes, or as we see unexpected findings, it's important, number one, to make sure that that is communicated. But number two, I think it's important from the patient's perspective to make sure that the recommended actions are tracked as well. And I think that's something that practically nobody's doing. We're doing it, but we rely on a combination of automated and manual systems, and I'd really love to automate that. Not only that, but when I make recommendations for follow-ups based on Fleischner criteria, for example, for lung nodules or other recommendations, I and most radiologists don't know whether those recommendations have been followed. And I think we have a responsibility to the patient in a manner similar to what we have for mammography to do some tracking of those recommendations also. And so I really would like to see a true closed-loop system, not only to track acknowledgement of information, but also to track to see whether or not there was follow-up on recommendations.
Elliot, very well said. I agree with you, because that's why I needed to think about this, because the way I feel right now is that we really don't, as much progress as we've made with technology, we're still creating just more complex silos. So we have to find those bridges between systems. So for instance, your example, which was excellent in regard to your following up with your recommendations, when you find an incidental finding, yes, you feel confident you're getting that information to the provider, but yet you're not feeling very confident that you're always hearing back from them in regard to what the outcomes were, whether they followed up or they did not follow up, or if they followed up and what was the result.
Exactly.
Ideally, what I would love to see in my vision would be that, and I think I have to say I'm giving CMS a lot of credit here in the ONC and what they're trying to accomplish with the standardization of this technology is that eventually these systems will be able to talk to one another, and that we won't necessarily have to have those manual as well as automated hybrids. Even though still voice-to-voice communication is still the most ideal, it's just not the most reliable, we should be working towards developing EMR to RIS connectivity, or the RIS becomes part of your organizational EMR, where those EMRs do have some type of communication between the two, so we could have that true closed loop.
I know, Elliot, you were talking about the provocativeness of, will Facebook or a social media fit into the sharing of images and in light of patient privacy? I mean, maybe that can be our closer here. What do you think?
Right. Well, it's sort of ironic because it seems as though if you look at, many users of Facebook, privacy seems to be the least of their concern.
It just depends on the age, I'm afraid.
Yeah, that may be true. But, one of the things that's really interesting is if you ask patients whether or not they would be interested in a national identifier, or whether you ask patients whether or not it would be okay for their images to be shared for research purposes, a majority of those patients seem a lot more comfortable sharing that information than I think many of the legislatures and many of the IT folks, at least that I've worked with, have. And so I think that the question is, who do you really trust if you want to make your images as easily accessible to those who are taking care of you? And right now, if you show up in an emergency room or in a place that hasn't been anticipated where you would be, it's very difficult to get your records. And where do you end up drawing that line? And as people end up using social media, the question is, do you trust social media like Facebook? Would you trust a Microsoft Health Vault? Would you trust the government? Exactly where would you end up putting your trust? But I think as time goes on, that there will be an increasing interest in patients in having mechanisms, whether it's social media or others, to make it so that their information is accessible when it really needs to be, and in a way where they feel as though it would be private and secure. And at least in that younger generation that you're talking about, I think there is an increasing trust in financial transactions over the Internet and in safe and secure sharing of documents using Dropbox and using Google Documents and many other means. And I think we're going to see the lag that we see between where technology goes and what healthcare adopts, but I think eventually we're going to see increasing confidence by patients as well in using the cloud and the web.
Well, I just wanted to echo your points, Elliot and Maureen. We're always talking about understanding kind of the process implications to all of this, and I think inserting the patient in some of your tracking mechanisms would be awesome. I mean, patients frequently have to serve as their own advocates, and it is tremendously difficult to collect images and health records from a number of different institutions, and they're probably the most motivated to make sure that in those key transitions of care that the guidance is carried forward and we close the loop on it. So I think those are excellent examples.
And I think it's interesting too. I think all of the points that we're making really come down to. I mean, the title of this webinar too is Smart IT Strategies for Imaging Growth and Quality Outcomes, and I think it does come down to smart IT strategies and making sure that things are available when and whenever they're needed. I think it's a good way to close, I think. So I do want to say thank you very much. I know this is a great Q&A for me. I know I've learned a lot, but we are going to stop. I want to thank you, everyone, for participating in today's webinar, and specifically Christina and Maureen and Elliot. Thank you very much for sharing your thoughts, and the discussion was great. And if anyone would like to listen to the webinar again or recommend it to a friend, I don't know if you joined late or anything like that, we will be emailing you a link to an on-demand version in the next day or so. You can also access it on our websites, clinical-innovation.com and healthimaging.com, right under the webcast tab. So thanks again and have a great day.